Hi, everyone. Welcome to another Prodigy webinar. My name is Maya Dorset. I'm the Medical Director of Prodigy EMS, and I don't even think I can begin to express how excited I am for you to join us for this webinar on 6 Minutes to Live, where we are going to learn from the co-founders of the 6 Minutes to Live movement, as well as watch the world premiere of their documentary. So let's introduce our guests. So the first is Bob Davis, who has dedicated his career to understanding and improving emergency response systems, leveraging his unique experience as both a paramedic and an award-winning national journalist for USA Today, where he specialized in aviation safety and emergency medical services. His investigative reporting has shaped his perspective on human suffering and community resilience. His diverse experiences led Bob to focus on promoting personal growth, encouraging community engagement, and improving emergency services, and he currently works as a well-being and leadership coach. We are also joined by Tom Bouthillet, who has dedicated his career in emergency cardiac care and improving sudden cardiac arrest survival for over 25 years in public safety. He recently retired as a battalion chief of EMS at Hilton Island Fire Rescue. As an educator, Tom is revered in his field for resuscitation excellence and emergency cardiac care. His combination of operational experience and the understanding of systematic improvements offers a valuable perspective to this examination of time-sensitive emergencies. And last but certainly not least, Hillary Gates is an educator, connector, paramedic, and advocate for humans. I have the pleasure of working with her on a regular basis as she is the Director of Educational Strategy for Prodigy EMS. She was previously the Editorial and Program Director for EMS World, and she teaches as a university adjunct in the fields of EMS education. Hillary's deep passion is speaking up for the voiceless and for vulnerable populations. Thank you so much for joining us today. What we're going to do first is that we are going to have the world premiere of the 6 Minutes to Live documentary. I'm going to warn you, if you do not have a box of tissues readily available, I would get up and get one. So we're going to dive into the video and then come back and learn from our founders.
Yeah, 400 meters, that was her specialty. She had a school record. Did you know about that?
Which?
That she had school records in all these disciplines?
No, I didn't.
Julia was very accomplished, very bright. Life as part of the team, that was very important for her.
She had a good sense of humor, and we had really a lot of laughter. To her, the next person was as important as herself, always.
She also has a special interest in dealing with kids. She spent the summer internship in DC, some kind of organization that fights for the rights of children. We got a phone call that rings in my mind every day.
It was 1999, and I was living in Washington, D.C. My husband Henry and I were coming home, and we drove onto our street, and we saw a couple of people standing around someone who seemed to be on the ground, collapsed, and not moving in the crosswalk. Very, very close by was a fire station, and we thought for sure that there would be a response by DC Fire and EMS, and we didn't hear any sirens, so someone took it upon themselves to run across the street. He tried to implore the folks at the firehouse to help, and he was told that they were changing shifts and they couldn't come.
We understood this to be related to cardiomyopathy. Apparently, that sudden cardiac event happens among the athletes. This unfortunately requires a very quick response time.
Finally, it seemed they paid attention and eventually came over and rendered aid. There was also more confusion with the dispatch and the 911 calls. We watched just in agony as we saw an ambulance coming towards us. When it got to the intersection, it turned the wrong direction. Finally, they placed her on the cot and then left the scene.
I've never felt so helpless. I just had nothing in my power to be able to make a difference in this woman's life. She needed CPR and she needed an AED, and she didn't get that in time.
That was a shocking realization, and how quickly our life could be shattered.
She died needlessly due to bystanders who didn't know what to do to help, and a fire and EMS system that, for some reason, was dysfunctional.
I knew nothing about how to help someone in that situation. I was a high school English and journalism teacher, did it for more than a decade, and then switched careers and became a paramedic. I work still as an educator, trying to bring the most up-to-date content to EMS providers who are learning how to do the best things that they can do for their patients.
Raise your hand if you know your survival to discharge rate percentage for your cardiac arrest patients.
Sudden cardiac arrest means that your heart has stopped beating normally and it is no longer perfusing and sending oxygenated blood to the organs. For every minute that a person's heart is stopped, their chance of survival decreases by 10%. It truly does mean that in the first 6 minutes of your collapse, your life depends on getting cared for right away.
I learned as a paramedic in Denver that life and death is defined by geography. Medicine doesn't like to talk about these disparities that are a result of medical systems. As a reporter, I was trying to show this nationwide. I wanted to show which cities were safer and which were not as safe. I learned about Julia Rusnick when I was doing an investigative series for USA Today on EMS performance across the country. And I was looking at the major cities and how they performed in cardiac arrest survival. And the Julia Rusnick case was a shining example of how tragic the care was in Washington at that time. We're losing between 1 and 3 airplanes a week of people like Julia Rusnick who could easily be saved. They're dying needlessly in this country. These victims of sudden cardiac arrest are kind of written off by a system that says, oh, well, we did the best we could. So what's missing is that analysis. There were 3 basic findings for my series. One was the importance of everything that happens within that first 6 minutes. The second element was once a city decides to try and save more lives and be very intentional about it, it requires them to have really active medical oversight. And the third part was the political will that is required to make these change is significant. It really got the conversation going in a lot of cities across the country. My hope was that every city would see that series and say, where are we on this map? What is our performance? And what gaps do we need to fill to save more lives?
Back in August of 1997, when I came to Hilton Head Island, I was hired on as a firefighter paramedic, and I did that for 24 years. I do remember reading 6 Minutes to Live or Die and being alarmed by it. I understood right away that Hilton Head Island was one of those communities that didn't know its numbers. We had no idea how many cardiac arrests a year that we responded to, how often there was bystander CPR. We were basically flying in the dark. We put a presentation together where we estimated the number of cardiac arrest cases we attended. We guesstimated pretty accurately how many of those were going to be witnessed versus unwitnessed and how many of those were going to be shockable. Let's say we saved 10%. Well, we said if we could just improve that survival rate to 40%, then we would have 6 survivors a year, which meant that in 25 years, we could save 150 people.
65-year-old male in cardiac arrest, engine 3, medic 5, arrive on scene.
So we made it our explicit goal to improve cardiac arrest survival, and we had got buy-in from the entire command staff. One of our deputy chiefs had the idea that we should mock up a jet airplane with 150 seats and hang it up on the wall of fire rescue headquarters. Whenever someone that had a bystander witness shockable cardiac arrest survived a hospital discharge with good functional capacity, they would get a seat assignment. So we would put a heart on that seat and the date of their resuscitation, and we would go about holding ourselves accountable for saving this 150 lives in 25 years. These changes that we made were sustainable.
Hilton Head 911, do you have a police, fire, or medical emergency?
We were just working out, and all of a sudden, the other person we were with noticed she was just laying down. She's not breathing.
Okay.
There are many cardiac arrest survivors that are meaningful to me, but one that stands out to mind just because she was so young. She was working as an intern at a place called Hilton Head Health, and she collapsed.
She's just laying on her back. She's not moving anymore.
Listen to me very carefully, okay? I'm going to tell you how to do chest compressions.
Her fellow interns worked together as a team. One dialed 911, one started CPR, the third one ran out into the parking lot to guide the incoming paramedics. And our telecommunicators did a really fantastic job. They made sure that the CPR was at the correct rate, depth, and recoil. When they arrived on scene, Amber was in ventricular fibrillation, paramedics applied a shock, and we got her back. I keep track of her on social media because we're friends. I saw Amber's boyfriend on his knee proposing to her. And then the very next picture, a big puff of pink, and I thought, oh my gosh, our cardiac arrest survivor Amber is gonna have a baby. When I reflect on Julia Resnick and all that was lost that day, to compare that to Amber, both of them 21 years old. In one case, system didn't work. In the other case, the system did work. One leaves a trail of devastation. The other, a beautiful young woman, gets married and has her own baby and has so much hope and love. What does that mean?
These are not just cases, these are people that need help. These are individuals. I see human lives at stake and human lives that could be either saved or not.
Cardiac arrest is not a death sentence, at least not in the United States. It shouldn't be. What gets in the way is system dysfunction. Like anything else, systems can be improved.
So it starts with public awareness and recognizing what sudden cardiac arrest looks like. It starts with bystanders being trained how to do CPR and highlighting certain systems like Washington, D.C., who have made enormous strides in improving their survival rates. The most important thing that an EMS system can do is measure what their performance is. Without measuring, we cannot improve.
If you make it your explicit goal to improve cardiac arrest survival, then you start asking the right questions, you start measuring the right things, and you start thinking about how your system is actually performing compared to how you think it might perform.
The public has a right to know this information. EMS and cities have a responsibility to act on it. And as citizens, we have a duty to pay attention. The change that's required to save these lives starts right here. It's personal will, it's caring. And once you get it and you care about it, then you can measure what's going on around you and you can take action.
What I'm hoping is that we're going to put this on the front burner and people are going to pay attention, and many thousands of cardiac arrest patients like Julia, like Amber, will have a chance of life.
Hi, everybody. Thank you for joining us. Thank you for sharing this with us. We're very pleased for this opportunity to be here, and we thank Prodigy for the support and helping us put this mini doc together and share it with you. Just taking a moment to take a breath and allow this emotion to settle in. It's emotional every time we see it. And we have so much respect for the people who shared their stories with us. And we're happy to share these stories with you and make you part of the story. One of the most common questions we get is, why 6 minutes? What's so special about 6 minutes? Many people understand that when someone collapses in cardiac arrest, that brain damage begins, and there's a general understanding that within 10 minutes, life and death is defined. But we focus on 6 minutes for a very specific reason. Science is very clear that when someone goes into ventricular fibrillation and the heart is in a chaotic quiver, chaos, it will last in that for only 6 minutes. It will degrade, and within 6 minutes, that will become flatline. That will become just what we all are very familiar with. That death image that we see on the EKG of a flatline. We can buy time with CPR, and what the heart really needs there is a shock from a defibrillator. But we focus on that 6 minutes because that is the reality. That's the scientific reality. That's just the reality of ventricular fibrillation. It will end in a flat line in 6 minutes. Every day in this country, we have 1,000 people who suffer sudden cardiac arrest outside of a hospital. These are in every community, all ages. This is a very widespread occurrence. Most cities are only saving 8% of those people. And by save, we're saying people who go home with good brain function. After the event, they return to a normal life. Survival rate on average is 8%. The cities that save the most lives, high performance cities, nearly double that to 15%. It's well established that by following steps that are simple, easily repeatable, but very specific, these cities who choose to get into this act of saving lives in a very dedicated way by measuring what they're doing, like Tom did in Hilton Head and so many others have done across the country, prove without a doubt that cities can double that survival. We are focusing intently on this difference in survival. This 66 lives a day can be saved in this country. 66 lives a day are being needlessly lost because of inefficiencies and a lack of awareness. As Julia's parents said, these are not statistics, these are people. Julia was a humanist. Her parents alluded to it in the video, but she cared about other humans deeply. She dedicated her life to other humans. And so we're inspired to do the same in her honor. This is a human condition. This is a human frailty. When someone suffers a sudden cardiac arrest, they're a soul in free fall. We have the opportunity to save these people. And that's what we want to encourage you to join us to do. This graph shows individual communities who report their sudden cardiac arrest survival in what is known as the CARES database, the CARES registry. Each one of these communities does the work to track their performance and reports it into this system so that everyone involved can get an idea of the disparities. If you're a community on the right, then you're one of the top performers in the world in this database. They use what is known as the Utstein measure. This is particularly important for people in medicine. This measure allows them to see how they're performing, saving the most savable. Some people who suffer a cardiac arrest outside of a hospital, they're at the end of a long illness and death is not unexpected. We're not focusing on that. With Utstein, we're focusing on the people like Julia, like Amber, who are otherwise healthy and suffer a sudden short circuit in their heart and collapse and are not only imminently savable, but they will return to a healthy, robust life if we intervene. So using this Utstein template, a city can look at itself and see where it is on this slope. And a city on the left can say, what do we need to do to become a city on the right? Question this raises for all of us is, where are you, Hillary?
Thanks, Bob. This is one way to look at the differences in survival rates across North America in this instance. And we absolutely should not be accepting this as something that is okay. Our mantra at 6 Minutes to Live is care, measure, and act. And as Bob so eloquently stated, we have to have the personal will to care about another human, a complete stranger, to put our hands on them and to make the difference in their survival, because we know we can, and we know what the science means behind bystander CPR and defibrillation and early intervention. So you're here today on our webinar because we already know that you care, and you are also probably an EMS clinician who signed up for this job because that's your mantra as well. You care for others. But do you know the survival rates in your community, in the community that you work, and in the community where you live? Do you know what your Utstein survival rates are? And if you don't, how would you find out? When I began working in EMS as a paramedic, I didn't know the answer to these questions. But as I got into the national landscape and had the great fortune to see what was going on across the country and indeed across the world, I was really very astounded at the differences in the way that EMS systems performed. So you, as an EMS clinician now, have a firsthand understanding of emergency response, and therefore your voice is very powerful in showing why every minute and every trained responder matters. And you also know that we can't be there in the first 6 minutes or maybe even 10 minutes of someone's emergency, and therefore we need someone living in our community. We need a bystander or a layperson to help us out with these time-sensitive emergencies. So we ask that you demand accountability and proper resourcing from your local EMS system. As someone who understands emergency response, your voice carries great weight in pushing for this honest response and in asking for the receipts from your community. And this is where we can compare performance of your own system to the best in the nation, following the adage, we can't improve what we don't measure in order to save more lives. And Tom will talk about that next.
Thanks, Hillary. When you start to measure things in your EMS system, there's different places you could start. You could measure individual performance with instrumented mannequins if you were doing some kind of CPR scenario. You could try to measure team performance when you look at things like rate depth recoil, ventilation, perishock pause, CPR fraction, things like that that happen inside the classroom. And you can take data from CARES, and you can do what I like to call diagramming. So in this particular instance, it's just a way to think about how your system performs. So we've got collapse happening here at time 0. The first interval is like someone recognizing that there's a medical emergency and calling 911 here in this, this happens at the 1 minute mark. Call processing interval here takes about 90 seconds. And so the call is dispatched at about the 2.5 minute mark. Again, time 0, the time of collapse. And the telecommunicators start getting hands on the chest. This is before the responding crews have even left the station, and I think that's a really key concept here. So if you look at how many minutes of telecommunicator CPR are taking place in this example, it's 6 minutes. So from minute 3 to minute 9, there are compressions happening on the other end of the telephone, and hopefully simultaneously in your system, there'll be an automatic alert for something like a pulse point notification that goes out to citizen responders who could potentially respond with an AED or an additional rescuer to help with the CPR. In this example, the ambulance arrives at the curbside of the emergency at about minute 8 and arrives at the patient's side at about minute 9, and the first shock goes on board at minute 10. So we've got collapse to first shock in 10 minutes. If you guys remember that graph, the slope of death that we showed you guys, that's if nothing is done. So in this example, the patient, the collapse to first shock interval is 10 minutes. Shouldn't this patient be dead? Well, yeah, if nothing was done, the answer is yes. But even in a high performance system, it's not at all unusual for the first shock to be at minute 10, minute 11, minute 12, and the patients still do okay because they're getting bystander CPR, often coached by the telecommunicators, sometimes dispatched to the scene by a citizen rescuer, something like that. And then finally, in this example, so we have 6 minutes of telecommunicator CPR, we have 6 minutes of high performance CPR that's on scene with the professionally trained rescuers, and we have return of spontaneous circulation at minute 15. So from the moment of collapse to the time the patient has pulse is again, we're at 15 minutes here, and I would even argue the patient's not out of the water yet. We have this whole other phase of post-resuscitation care. But this is an excellent way to allow individual calls, give you a lens into system performance, and depending on how good your data is, you could have a representation like this that shows how your system performs as their average performance or even at the 90th percentile. And of course, by the time you're done measuring all these things, you should have a pretty good idea of the things that your system does well. And you probably have a good idea of those things that your system could probably do a little bit better. So once we care and once we measure, we start to think about our system in a new way, and we start to think about its actions differently. And then we can start to implement countermeasures as we go on our quest for continuous quality improvement and operational excellence.
I think it's a little bit difficult to be in the position of where to start because I think there's a lot of big feelings and a lot of important things to say. But I wanted to insert a little bit of a reflection here, which is what a remarkable thing, like the legacy of Julia and as well as Amber, and how it can inspire people to change and the lives that have been saved as a result of it. I think is truly a remarkable thing. When I, listen to you talk about not just the story of how you came together, but what's going on in our communities, I reflect on how far have we come, right, where we have communities that are measuring and communities that are acting and improving care. But what are some of the things that haven't changed, which is the reason that this movement needs to exist? And if I think about where do we go from here, and Care, Measure, Act, what I actually hear is that I feel like I need the answers to sort of 3 questions, or the listeners need answers to 3 questions that they can take with them, think about, and then bring back to their communities. And those 3 questions are, why do we care? What do we measure? And how do we act? And so I'd like to take a little bit of time to explore those 3 questions before I have to share you with the audience for the rest of our Q&A. So Hillary, I'm going to turn it to you first, which is, why do we care?
Thanks, Maya. You're exactly right that we need to answer these questions and understand our own role in each of these parts of our movement. Bob and Tom and I have decided that storytelling is the way that we want to get this passion across, and all three of us have this passion, and all three of us care very, very deeply about changing the amount of people who die needlessly from sudden cardiac arrest. And when I think back to the trajectory that brought me here today, it is remarkable, as you said, Maya, that the tragic death of Julia led to me becoming a paramedic in so many ways. When I stood there as a layperson, as a bystander, as someone who had no idea how to help this young woman, and I watched her die in front of me, I knew that something was very, very wrong. And yes, at the time there happened to be a system dysfunction in the city that I lived, but the the most important thing was that me as a bystander, that I couldn't help. And so I remember that feeling. I will always remember that feeling and regret that I couldn't do more for Julia. When I had the great fortune, as I said earlier, to work in a national role in EMS, and I saw the ways that places like Hilton Head Island Fire Rescue and Seattle, Washington, and other systems worked and how well they performed and how they measured, I realized that they cared enough to measure. And so when I now look at the difference in my perspective of being a bystander and a layperson who felt helpless, and then moving to being a paramedic and someone who could change the national dialogue, I realized that there's just no question that I had to do something. And that's why we have to care, Maya, because uh, we know the truth and we know what to demand from our systems. And we know, again, what works in saving people from sudden cardiac arrest. And there really is no reason why all systems shouldn't be doing it.
Bob or Tom, do you have anything to add to that?
I think that when a community commits itself to improving cardiac arrest survival and makes it their explicit goal, and they start measuring things like that, and the medical director is involved, and the chief's involved, and things like that, and they're all together in the training sessions, building that esprit de corps and kind of breaking bread and having conversations, because I think organizations can get caught in a rut where certain perceptions have been in place sometimes for decades. And so to really make a change that lasts, it can't be done by memo. You know, it has to be done by new experiences, shared experiences, you know, so that people can sort of see themselves in the solution. And so it's just an incredible, I think, opportunity for an EMS coordinator or an EMS chief or a medical director to bring this issue around and get that initial buy-in, because it's really powerful for the guys and gals out on the street that do the work to like see a medical director and an EMS chief get in their hands and knees alongside everybody else and say, no, we're going to have a new standard for excellence in resuscitation, and we don't have all the answers, but we're going to show you the science and we're going to show you how we think we're doing now, but we're going to implement something new, and you guys are a critical piece of that, and we're all going to do it together. You know, will you help us? And that's going to solicit like, yeah, absolutely. Yes, we will do that. We will be part of that, you know? And so when you do that together and move the needle, it can really, I think of it as part of an antidote to our like COVID hangover and all our quality improvement initiatives that were burned to the ground during that terrible time, and all part of our trying to get our mojo back and, you know, in some cases get our self-esteem back, or just, you know, remember that medicine is a noble profession, and that part of the social contract is that we're out there on our street every day trying to do our best to give people their life back. And so to be able to actually do that feels really, really good. And so I think it can be part of individual healing. I think it can be part of organizational healing too. And plus, it's just the right thing to do.
Tom, what they said is just this is why we're together. We resonate on this wavelength. And we know that people who become aware of this care deeply, share our care and concern about it. And they oftentimes wonder if they'll be ready, wonder how they can turn their care and concern into action. And as Tom said, it's a moment of healing because this is a moment for the communities to act. This is a moment to enable and empower people to bring their care forward for someone who may be a loved one, but it may be a complete stranger. It doesn't matter who it is. Saving a life is an extraordinary, extraordinary gift to everyone involved.
Oh, I think that's the perfect transition to what do we measure? Because as I watched that video and then I saw Tom break down the timeline, and I think that there are things that I sometimes measure as a medical director within my own system, but there's not that many response times that are less than 6 minutes from when the person collapses. So whether or not I'm talking to the broad audience, whether I'm an EMS clinician in a service or I'm a chief or a medical director, or it's my mom or dad who are non-medical people living in a community. Can you explain what should we be measuring and even more how that should be shared with the community?
Yeah, I think, when I did the series, the headline was all about survival rates. Those were the measures that got everyone's attention. But another measure that we collected was the citizen CPR, how often citizens were performing CPR before anyone got there, how much the cities were investing in training their communities, how much awareness they were raising in that community role in the response. And I think that it's really important. Of course, we're going to measure survival. Of course, we're going to measure all the intervals that systems need to measure to improve their performance. But to your question about communities, we also need to really pay attention to what is our community engagement. Because as you said, Maya, EMS is not going to get there in time. And so what I'm hoping for now, coming around at this again, what's changed in communities is the technology is there, the science is there, we know how to do this, and to really empower the community as the real first responder in this situation. They're right there. Our telecommunicators are going to help them get hands on chest and do what they need to do. I think for me, that's really where we need to bring sharper focus and more solid engagement.
So, Tom, in other conversations we've had or in listening to you speak, one of the things that I've heard you say over and over again is that your performance on cardiac arrest reflects the health of your EMS system. Can you expound on that a little bit and explain your thinking?
Sure, I would add in the what's happening in the 911 center as well. If it's a 911 center in crisis, I would say that's not a good sign for the public health of your community. One of many, not the only barometer, but I think when I look specifically at sudden cardiac arrest, because it is the mother of time-sensitive emergencies, and because it impacts the community from the standpoint of like recognizing cardiac arrest, making a 911 phone call, does that 911 call go to the police? Does it have to be transferred over to EMS? How accountable is that process? How many seconds did that take? How many seconds into the call until they had confirmed the address and dispatched the first unit, and then wheels up to wheels down at the curbside of the emergency? Just that is a lot of coordination. Just that is a lot of like every day at the office, yes, but depending on your policies and your procedures and your protocols and the relationships between these dispatch centers and their relationship with you, for you to even know what this information is, and whether or not they're doing something as sophisticated as tracking the AHA's TCPR performance measures. To do all those things implies a lot of hard work, that you got out of your silo and that you had productive conversations between a fire chief and an EMS chief and a comms director and a city manager, or maybe your city council, and beyond. To me, if you're doing cardiac arrest well, I think there's an excellent chance that you're a high functioning organization that could handle pretty much any challenge that you set your mind to. I just think you're operating at a high level if you're able to do those types of things.
When I think about what you say about, the health of the EMS system and what do we do with this data, um, in the presentation you talked about and you showed the numbers of the difference between your outcomes if you live in one community versus another. And you actually called it a disparity. But in sort of quality improvement terms, a health disparity means that there's just a difference, that it's like sort of the natural byproduct that it will be a difference. And I think this is actually what is an inequity, means that there is a lack of justice to it, that is unjust, that you're going to have two different outcomes. And I think when it comes to cardiac arrest outcomes, there's inequities because my survival shouldn't depend on what zip code I live in. And, I was talking to my parents and my in-laws about this because they asked, like, how would they actually find this data? Like, how would you know as a community member? And we had this discussion, and I said, like, when I go to, look up a house or something, or I'm investigating a neighborhood, I can see the performance of the schools. I can see the performance of the safety of the neighborhoods. I can see all those different things, but there's nowhere I can see on, realtor.com or Zillow, the out of hospital cardiac arrest survival. Um, and I want to actually have a productive discussion about why. Would that be a bad thing? Would it be a good thing? Yeah. So like, what I know that I think we share that I think that that would be a good thing, but let's talk about why, because I think there's a lot of us who are first like kind of horrified that our perhaps our dirty laundry or lack of performance would be public knowledge.
I'll jump in on that and then ask them to share too. The cities that measure this really well and take this very seriously, they see those disparities, those injustices on their city map. You can see areas in communities that have lower survival rates in the same city or county. And that is dramatic. And people need to see it because we can't fix what we don't measure. And when you see it on a map and you say, why is this community over here uh, struggling so? How can survival be so dramatically different? That's when you start to act on it. And it is an injustice. And I'd like for Hillary to talk about that. Hillary witnessed an injustice. As we said in the film, Washington, D.C. has made great strides, and they're a city that now can show those disparities in different communities because they take this so seriously and they've made so many improvements. But more than 20 years ago, Hillary witnessed the injustices that were very common in Washington, D.C. So, Maya, I think you bring up a really valid point, and I'd love for Hillary to talk a little bit about how motivating it can be to have awareness of that.
Thanks, Bob. There's absolutely ways to look at maps, just like the one I showed, that would show very, very scary inequities within a 12, 15-mile radius in the same community. And we see that among many health conditions, but this is one of them that we can chalk up to lack of bystander intervention because usually there's lack of awareness and no training provided and lack of things like AEDs. DC Fire and EMS has done a tremendous job measuring what's in their system and in their city. And they have pointed to areas of Washington, D.C. that have AED deserts. There are many, many, many AEDs along K Street in Washington, D.C., which is a highly trafficked, highly affluent, populated area of Washington, D.C. And in the poorer neighborhoods with Black and brown citizens, there are no AEDs, and that needs to change. And we know that there are incredible inventions and industry folks who are doing amazing things with the ability to put AEDs in areas that need them, and those are the types of places that need them more than others. So when we look at the measurements of the health of a community, Maya, you're exactly right. It would be quite a thing to be able to put that on a realtor website. And that's what the purpose of our survey and the relaunch of our survey is. When Bob and Tom started talking about this a few years ago, Tom, kept saying to Bob, let's relaunch this. The numbers haven't changed enough. There hasn't been enough improvement. And so that survey will be available to all medical directors, and we can share the data honestly and show the receipts of the community that you live in so that you know what is being neglected and what can continue to be championed.
And when I think about that as somebody who is a medical director or part of the EMS system, right? At the same time, I am also part of the community, right? And so while I want to get better and I might be nervous about sharing some of that data, knowing that it is a necessary, uncomfortable step in making the system better, as a community member, right? Like I also want sort of accountability to try doing the right thing and driving performance. And all of us, while we may be EMS clinicians, are also just private citizens living their lives with their families and all of that. All right, so I want to make time to answer one more question because I actually showed, I mean, this is the world premiere, but there was a living room premiere over Zoom where I showed this video to my parents and my in-laws. And the first question my father-in-law asked was like, well, what can I do? What can I do? I'm ready. So I put the question to you, right? How do we act? What do you want people to do?
Yeah, it was a tremendous thing to be able to show this to some of our family and friends. And my parents had the same reaction. My dad wanted to get up and start CPR on someone, and train his senior living community, and we got to do that a little bit with the help of King County Medic One. My parents live in Seattle. The ACT part of this is where our movement takes off. This is where we fly. And when you feel empowered and you know that you want to care for someone who's a complete stranger who's in dire need of your help, you need a place to go and you need a call to action and a plan. So part of our movement will be to share on our website ways that you can do that. And whatever your wheelhouse is, whatever you feel passionate about, whether it's training others in CPR, learning CPR, advocating for more AEDs in your community, going to your city council or your community civic organizations and saying, we need to know what our survival rates are and we need to improve them. Whatever your passion is where we want you to direct your efforts.
Bob?
I think if it's a interested citizen, I would like them to contact their representative on the city council and schedule a coffee date and tell them that they watched a really great video that got them thinking about cardiac arrest survival and ask them if they know anything about their emergency services, and strike up a relationship with that person and do the same thing with the mayor. And then reach out sometime to the fire chief and stop by a fire station and just start talking to the guys. Just become engaged with your local officials. And I think if you're a system level type, like a medical director or an EMS chief or an EMS coordinator, something like that, you can pull your last 10 bystander witness shockable cardiac arrest calls, analyze those calls and ask yourself honestly how your system performed, maybe pull those 911 calls and dig in, track the HA's TCPR performance measures, find out what's going on in your 911 center. And if you need help, give us a call. We'll help. We'll help you. And then from there, you can reach out to a Resuscitation Academy Lighthouse and ask for some guidance and things like that. And one really nice thing is every high performing system that I've ever reached out to has been incredibly receptive and courteous and happy to spend time on the phone and explain things. So there's a lot of help out there is the good news if you want to go on this journey.
And I would just add that that's how we came together.
we're helping each other. We're showing up for each other. I think that if people are inspired about this and maybe they feel a little nervous, like maybe I'm not ready. I took a CPR class back a while ago. You can go to your local firehouse. You can stop in anywhere. You can reach out. There's lots of people who want to talk about this and want to help do something. So it's noticing where you are, what you want to do, and also noticing if you feel uncomfortable about something. Not really ready? Ask your local firehouse if you can practice on a mannequin. They're more than willing to help you feel secure. Just, I think, bring it up, bring it forward. Really, Maya, is what we want. Meet people where they are. And if they have any inspiration, aspiration, desire, just talking about it and sharing it with someone else and finding someone else who shares that with them, they'll be surprised. That's really what happened with us. We talked about it, we shared our passion about it, and now we can't stop talking about it and we can't stop doing something about it. So I think that wherever you are in life, it's an opportunity to do something really incredible for somebody. We call this, sometimes Hillary calls this 6 minutes to love, because this is an act of love, right? This is an act of compassion. And it's something that we all need right now. It's a great way to bring love and compassion into our communities. Um, we don't care who it is, any stranger, doesn't matter. This is about us showing up for each other, and just, as I think Julia would be very proud of us, just being good humans.
We're going to turn things over to the live Q&A. And for our audience members, if you add in questions into the Q&A, we're going to continue to go through and answer those. But I'm going to challenge you to do one more thing, which is into the chat. I would like you, if you're in the right place right now, to make a commitment of what act you are going to do. And it can literally be very small or very big, but something that is within your power today, to change for tomorrow. So let's get started with the Q&A. Hi, everyone. This is tremendously exciting. We have almost 1,500 people on this live webinar who are still here, and I think it just speaks to what an amazing topic this is. And I think they're still here because of the passion you have for making a difference. We have a lot of questions. I've tried to sort of sort through and group those together. The first one I'm actually going to throw to Tom, which is there was a lot of questions early in the webinar about numbers and survival after out of hospital cardiac arrest. And I was hoping you could revisit those numbers for us and clarify them. So do you want to clarify those things for us?
Absolutely. So that data came straight from CARES, and it was in the 2023 annual report for all non-traumatic cardiac arrests, whether they were witnessed or unwitnessed. So if they received a resuscitation attempt out in the community, then they go into the CARES registry. For those all comers, so it doesn't matter what your initial arrest rhythm was. With the non-traumatic report, it doesn't even necessarily need to be a cardiac cause. I think this is a better report to pull if you're an EMS leader, because too many cases get kicked out when you say presumed cardiac cause. We're already cherry picking, and we don't always know, if we don't get an autopsy back, what the cause of the cardiac arrest is. So I'm a full believer. Just run the full non-traumatic cardiac arrest CARES report. Of those, according to the national data, all comers, regardless of arrest rhythm, doesn't matter if it was witnessed by a bystander, 10.2% survive. Okay, so that's our survival rate. But of course, not all of those are neurologically intact. So if you do the math to see who was CPC 1 or 2, meaning, they can take care of themselves without a family member assisting them in their aids to daily living, that figure is 8.1%. So that is pretty close to our actual survival rate in the United States. If you were to say, well, what about the most savable of those? Which of them had a witnessed collapse by a bystander, and which of them had a shockable rhythm on arrival? Brendan and I were just talking about this in the comments, and there's a lot more to say about this. But if it was bystander witnessed and the first rhythm EMS had was shockable, that survival rate in CARES is 32.8%. So that sounds a lot better, but it's actually 28.9% that survive CPC1 or CPC2. So our overall survival rate, about 8%. Our so-called Ustine survival or bystander witnessed, again, this is not traumatic, just suspected CARES reports, we're around, 29%.
Bob, do you have any more thoughts on that?
I would just add, you can see why Tom is our data expert. And I would just add that when I travel around and talk to people, people start talking about the data, they get in the weeds, and I just ask them to turn it around and ask themselves, what is your real data? How is your system performing? It's great to look at other data and compare it, but I think the most important question here, Tom said it before in the video, where are you in the solution? Find yourself in the solution. And if you're curious about data, you're thinking about it, you're doing the math, really make sure you're taking a good hard look under the hood at where your system is.
I think it's also a really good example to talk about positive benchmarking. I think people say, are we below or above the average? But I think when it comes to the communities we want to live in, we aspire for more than, we're not the worst. I think positive benchmarking is that you can look at really high performing systems and see that this is actually something that is achievable because somebody has achieved it and say, how do I replicate those things within my own system? Which I think gets us to one of the other topics. We are fortunate enough to have a lot of people on this webinar who are from rural systems. And amongst the many inequities and outcomes that we have from cardiac arrest, one of them is sort of geographic and community based. I'm wondering specifically around rural systems, but sort of suggestions for all systems. What are potential solutions that have been successful in that context for improving survival? Tom, I don't know if you want to take this one or really any of the panelists.
I'll take it.
All
Yeah,
right.
Maya, this is a reality. We don't all live in resource heavy systems and communities, and there are lots and lots of places in this country where when you have a cardiac arrest, there might be a rural responder, one volunteer, that kind of thing, and the equipment and personnel are lacking. So when we talk through these types of issues, we do know that there are solutions. They're a little maybe trickier, a little bit more involved, but the solutions involve technology. The solutions involve bystander and community awareness and participation. And this gets back to the entire gist of our movement that in the first 6 minutes, when we can't get there that quickly, we need your help and we need the community to engage. And yes, 70% of cardiac arrests happen in the home. Some of them happen and no one is there to help them. And those are going to be next to impossible until technology and Apple Watches and whatever changes that. Those are going to be next to impossible to respond to. But that's why we talk so much about witnessed and shockable and the needless deaths that we can prevent by being there with CPR and an AED and having community training. So, of course, things like telephone CPR, things like drones, things like communities who are, fully trained and there's an AED in a neighborhood or a public access AED. Those are the types of things that we're going to need to be able to get to folks whose EMS responses are going to be longer.
Yep. And I think a lot of things, who are your responders? There are systems where, right, troopers, police responders, community responders. I think all of our original metrics around cardiac arrest were when we thought response looked like one thing, which was a medical provider. But I think that has all been redefined. So thinking creatively about the organization of your community and how do you get the resources to the patients who need it, those solutions are going to be different. The change theories are a little bit, the same, which is I have to get this resource to this patient. Along this care inequities, we talk a little bit about geographic inequities. There was some commentary about AED deserts and access to the resources. And that is true in rural communities. It is also true in urban communities. And Hillary, I know that you are very familiar with some programs that have used data to specifically address these. Can you talk a little bit about those?
Thanks, Maya. The AED deserts are real. And our friends in Washington, D.C., under the leadership of Bob Holman and Greg Dean and Amy Morrow, and the folks who have really turned D.C. Fire and EMS into a higher performing system, they have taken their data and heat mapped where there are, AEDs and where there aren't. And as Bob Holman said in the chat, a former medical director from DC Fire and EMS, they were able to map that in one block of a affluent, highly populated area of Washington, D.C., there were way more AEDs than in the places that are socioeconomically depressed and not populated as much. So when we know our data, and this is back to our mantra of care, measure, act, we can fix it and we can address it. And there have to be ways that we fix these problems by looking at what works in other communities. Again, back to the rural question. When we know that there are solutions to these problems that others have used, we need to R&D, as Peter Antevi always says, rip off and duplicate those techniques, because there's no magic answer here that we don't have yet. That's the beauty of our movement. We know what works to save people. We just have to get together and implement it.
And Tom or Bob, if you have anything you want to add to that.
With regard to community size or the challenges of rural environments, one of the things I just mentioned in the chat is that telecommunicator CPR and law enforcement AED can be a match made in heaven for that. So when Peter and Dan and all the rest of the people from the Florida Resuscitation Academy use data to find like the most rural areas around the entire state of Florida that had the most difficult survival rates and things like that, and targeted them with mini academies. And I remember one story, and this isn't unusual when you target an area and go in and do high performance CPR training and break bread and start having these conversations. Within like 48 hours, a telecommunicator that was in the class and a law enforcement officer that were in the class worked together to save a life. Like she took the call and he responded with an AED. So you see a lot of times when we do these regional training events and things like that, it is not uncommon for the phone to ring or to receive an email like within a week saying, guess what? We saved a life. And like, that's my challenge to everybody. Shrink the change, start small, save that first life. You know what I mean? Focus on that. It's very encouraging. You're going to want to keep going when you find out that the things that you do really can affect other people.
When we instituted in my agency in Northern Virginia, CPR, when we put AEDs in the police cars and those police officers responded, we couldn't get them off the chest, right? This was one of the greatest joys of their job, was to be able to go to someone before we got there and set up that patient so that when we got there, they were viable. There are communities like that throughout this country who have done it. If your community isn't doing it, you need to be outraged and you need to demand that that's happening.
Okay, I don't know what it is about when Tom speaks, but when he talks about saving lives, I get like emotional chills. He's always the part that I break down. And I think it's your special power, which is to connect data to the human beings that we save. And you think about the system design, and at the end, it's like these are real people. And these are like real saves that people take with them in their career. I want to talk a little bit about data, and I'm going to talk about it with you, Tom, because there was all these things. There was some commentary about ISO ratings and standards, and we talked a little bit. One of the big barriers is there's the barrier of collecting data, and then there's the barrier of sharing data, and sort of all the clump people have around putting that publicly. For those of us who do not work and live in the fire space, can you describe what an ISO rating is and what is currently included in the standards and how you think, or whether or not you think those things should change?
Yeah, I think it's super important to understand that while I would say ISO ratings have a disproportionate influence in the fire service and are not as influential in our, certainly not our residential fire insurance rates that people think. It's used mostly for commercial fire insurance. And the first thing to understand, there may be some very fine people working at ISO. They do not care about cardiac arrest patients. They don't even care about the lives of firefighters. They care about buildings. They're there to ensure the building. They're not there to save a firefighter's life. They're not there to save a citizen's life. What they care about is things like your water supply, how well hydranted you are, how often you inspect your hydrants, how many stations you have, your response times, types of apparatus, how many respond, like how you train, and how often you go and inspect these buildings. So you can see what they're worried about. They're worried about loss, fire loss, and the buildings in particular. And so once you understand that, you realize that's not the forum that fire chiefs should be talking about when they do a community risk assessment. They should be joining with organizations like CIPSE, which is a Center for Public Safety Excellence, and do a comprehensive community risk assessment that looks not just at fire suppression, but looks at all of the different risks to your community. And sudden cardiac arrest is a significant risk where we can make a huge difference. So with or without ISO, though, and with or without CIPSE, you can go on this journey alone. And one thing that we have found out is that communities that do go on this journey, they want to talk about it and they want to let you know what they've done. They like to show their receipts. They like to discuss best practices. Maybe Ada County's had really good success with the police and carrying AEDs. Maybe Hilton Head's made some inroads with the telecommunicators. Maybe another place has a really innovative training program with athletic trainers and coaches and things like that. So this minded global community of people that are addressing this topic, you can tap into that and you will be welcomed with open arms.
So, you know, this seems like a pitch for 6 Minutes to Live, which is a community of people centered around the human beings that we are trying to save um, to make a difference. And so in our earlier Q&A, we talked about some things that people can do in your communities, and you just gave some phenomenal examples of change theories that might make a difference. But at the end, right, this is a 6 Minutes to Live webinar. You have come together centered around your passion to make a difference. So if people want to become involved in what 6 Minutes to Live is doing, how do they do that?
Bob can answer that one.
Oh, you think? Yeah. Go to our website, follow us on social media, reach out. We're humbled by this turnout in this community. This connection, this group love here for the cause is what we're all about. So let's keep talking. Let's keep sharing our stories. There's so many amazing stories out there. Narratives drive us. I mean, this is from our heart. As I said, it takes courage to step into this and to drive change. And, courage is hard action, right? Core zero. I never had more courage than when I was going to a cardiac arrest, right? It's galvanizing for us to come to the aid of somebody who is in our need. And it's a great opportunity for us to come together. So stay in touch and let's talk amongst ourselves. This whole conversation has been very humbling and very inspiring.
When we came together and thought about how we wanted to launch our movement and get everyone to get on board with us, we had so many ways that we could have done this, and we landed on storytelling because we are focusing on the humanity, just as Henry and Rosa talked about in the video, just as Tom discusses when he talks about Amber and her ability to continue to live a life of purpose and have a baby, just as Bob talks about with his emergence from 20 years ago, writing this article series and understanding that things haven't changed enough. We need to tap into the humanity and the love that we all have for each other, and the ability that we have to save each other is in our hands and it's in our hearts. And so, Maya, when you ask about what is 6 Minutes to Live going to do, or how can people help, we really also want everyone to be able to do the thing that matters to them. And when we look at the incredible champions who are here today on this webinar and who are working in this space long before we got our movement off the ground, Parent Heart Watch, Sudden Cardiac Arrest Foundation, all of the public access defibrillation, advocates who are out there. These are people who have a connection to a sudden cardiac arrest, some a connection that is extraordinarily tragic, and some that is, seemingly miraculous, or not miraculous, right? They just got the science and the things that we know that they needed to survive. So 6 Minutes to Live is a place where we want to aggregate all of those stories. We want to be the provider of all of these resources. And if you decide that your passion lies in defibrillators in your community, or your passion lies in community activism, or training people in CPR, or supporting our telecommunicators, or demanding the receipts, then you should go to our website and find the way to do that, and look again, as Tom said, at the communities who are doing this successfully, and ask for their advice and their guidance, because again, we know what works.
If I were going to sort of end this on one idea, I think it's that everybody can make a difference. And it's what difference can you make? Because every single person can make one. Thank you so much for everything that you're doing, for all the feels, for the inspiration. And thank you to the over 1,000 people who are still here for the Q&A. Think about the force multiplication to do good. It's kind of inspiring. So thank you, everyone. I hope you have a wonderful and beautiful day.